It is really an honor for me to be welcoming you all to this really quite special webinar as a joint effort between ESSO and the Brazilian Society of Surgical Oncology. So in the name of ESSO, as the working representative of the peritoneal surface malignancies working group, I would really like you to welcome you to this webinar and tell you just a couple of words about ESSO. As you know, ESSO is the European Society of Surgical Oncology. It's an organization that is really dedicated to promoting awareness and growth of surgical oncology as a subspecialty of surgery that we know is essential for outcomes in cancer. ESSO is a very dynamic organization, it's a growing organization. It has now reached more than 4,000 members. And it's really very, very interested and dedicated, especially to education through a whole host of activities that some of you are probably, some of them are familiar, like webinars like this one that we're having today. But there's also many other things. There are hands-on courses, there are theoretical courses, and then of course there is the annual congress that actually just recently opened up its window for abstract submission. The Congress rotates its sites throughout Europe, and this year is going to take place in Sweden, in Gothenburg. We got a brief announcement about this Congress at the end of last year, ESSO, in Antwerp, and it really sounded very, very promising in terms of the host country, the host city, as well as the program. So I would really like you all to keep that on your calendar and invite you to submit your work and to come join us for ESSO in Gothenburg. So without further ado, I think today's program is really exciting, very innovative, very, very cutting edge, and I'm very excited to listen to our moderators today and our experts. But before that, I would like to give the word to Rodrigo Nascimento, the president of the Brazilian Society of Surgical Oncology, who will tell us a few words. Thank you so much.
Thank you so much, Lana. We have much to discuss here, so and enough time, not enough time. So on behalf of Brazilian Society of Surgical Oncology, I extend our deepest gratitude to everyone who participated in this joint webinar. I would like to express our sincere appreciation to ESSO. Special thanks to our president, Goere, to the board of directors, to the secretariat. Your collective effort to facilitate learning and collaboration across borders has opened huge avenues and beautiful bridges with Brazilian societies. So thank you to our distinguished speakers and to our attendees. Thank you for your active participation and contributions. Your enthusiasm drives this conversation forward and turn ideas into impactful action. So I'm excited to start this debate, and I'd like to invite Arthur and Professor Akaishi and Professor Diane Goere to start our debate, our discussion today. So it was a pleasure, and we are flattered to be here with you. Thank you so much.
Thank you, Rodrigo. Thank you, Lana. I am really happy to be here. I would like to announce and also to start the webinar, Professor Eduardo Akaishi, that is from University of São Paulo Medical School in São Paulo, and Professor Diane Goere, that are going to moderate this session with me, and with pleasure are going to present the speakers from this webinar.
Hi, everyone. Welcome to the webinar. First of all, I'd like to thank the ESSO and SBCO, Brazilian Society of Oncology and Cancer, represented here by Dr. Lana and Dr. Rodrigo, for this kind invitation. In the setting of peritoneal metastasis after cytoreductive surgery in HIPEC, the prediction of a cancer recurrence and progression is an area of intensive effort research, given the high morbidity associated with this procedure. Today, we have the opportunity to discuss the role of ctDNA and CRS in HIPEC with a leading expert in this area. So I'd like to present the first speakers, Dr. Niels Koch from Netherlands Cancer Institute. He is going to talk about how ctDNA can help selecting patients for CRS and HIPEC. Please, welcome.
So thank you very much. Can you see my slides now?
Yes.
Thank you so much. I'll just start. I'm not sure if I can advance my own slides. Yeah. So as a surgeon, I have nothing to disclose. And I would argue that the current revolutions in oncology are implementation of immunotherapy and circulating tumor DNA. Assessment of circulating mutant DNA has been around for quite a long time, and it started in chronic virus infections like HIV. But this publication is from 2008, so it's been around for quite some time. And when I did the search on PubMed this morning, the number of hits I got reflect this, which is almost 1,000 hits for ctDNA and colorectal cancer. But when you break this down for ctDNA, colorectal cancer, and peritoneal metastasis, you can see that the evidence is actually very limited. So I would like to rephrase the title a bit and emphasize the can in this title and the question mark. And I think we have to rather have to extrapolate data from stage 1 to 3, and for the patients who got systemic disease to learn something for our patients with peritoneal metastasis who we try to select for HIPEC. So first, some words about ctDNA. This refers to fragments of DNA from the tumor which can be found in the circulation, and the mutations there derive from the tumor. What is important is that the fragment of the DNA derived from a tumor has a different length. And you may question whether this is just a new hype after circulating tumor cells, microRNAs, and tumor-educated platelets in the last decades. What I heard quite often during the last 5 years is you cannot do anything if you're ctDNA positive. So why should a patient know it? But we all know in this webinar that colorectal cancer is different from other cancers. Local or local regional treatment of metastasis makes sense and may even cure the patient. So both from the primary tumor and the metastatic tumor, molecules get into the circulation, and we can detect this as circulating tumor cells, ctDNA, circulating tumor RNA, or proteins like markers we're all familiar with, like CA and CA19-9. So these blood-based markers may help us for screening and early detection of cancer, to assess risk of metastatic relapse and prognosis, to target therapies, to assess tumor heterogeneity, for real-time monitoring of treatment response, and to stratify and make decisions when we give patients our therapy. This is just another schedule where we can use serial liquid biopsies early in the time of the patient journey for early detection, which is on the left, and then after surgery to see if there's some disease left, which may help to select patients for adjuvant chemotherapy. Then we can use these markers during follow-up, but also when the disease recurs for monitoring. And as surgeons, we're mainly in this part of the patient journey. So why should we select ctDNA? ctDNA has a quite short half-life of minutes to hours. It's rather stable, and you only need a limited amount of blood. In the past, I was involved in some research for circulating tumor cells, and it took quite some tubes actually, and it was quite cumbersome. It's easy to repeat these blood samples, and in particular, the stage of development is quite far. It's commercially available in the USA, not in the European Union, but it will get there. This is when I visited ESSO GI last year, and this is just a commercial out on the street of Signatera from Natera, who is one of the leading companies in the USA. So it is around there, and it is available. So when you divide ctDNA tests, we can divide those in agnostic and tissue-informed tests. So in tissue-informed, you know something about the mutations in the tumor. For agnostic tests, one of the things you could use is fragmentomics, which relates to the fragments which are different in tumor DNA. We can use a PCR method if we know the gene mutation, but of course you could also use gene panels, whole exome sequencing, or whole genome sequencing. And this makes tests either cheap or expensive. The workflow may be very simple or maybe very complex. If you have to send your blood samples first for whole genome sequencing and then to a different company to get it done and to get a result back, it may take some time. It depends whether we're looking at minimal residual disease, which reflects to circulating tumor DNA usually after surgery, versus circulating tumor DNA during monitoring, and the sensitivity of the test that you need may differ. For MRD, you need a very sensitive test. ctDNA is often expressed as a variant allele frequency or as tumor molecules per milliliter, and the term clearance is often used, which refers to the state that it can't be detected anymore. I would argue that detectable versus not undetectable ctDNA is a better term actually. So you all know this quote by Blake Cady, who passed away in 2023, about biology, which is king, and selection of cases, which is queen, and ctDNA may help us here. So what can we learn from other stages? Every stage actually has its own questions. And when you look at stage 2, we had this dynamic trial in Australia where patients were randomized to either ctDNA-guided adjuvant chemotherapy or standard of care. This was a non-inferiority trial with disease-free survival as an endpoint. Over 400 patients recruited, of whom in the intervention arm, 15% were ctDNA positive. And fewer patients in the intervention arm received adjuvant chemotherapy, which was 15% versus 28%. Disease-free survival didn't differ between groups, and there is a signal that the patients who were ctDNA positive had a worse disease-free survival. So in stage 3, the questions are different. So in stage 2, it's rather which patient does need chemotherapy, and here it is in which patient we can de-escalate and which patient doesn't need chemotherapy, and in which patients we have to escalate treatment, which is about intensifying systemic treatment. We have to take into account that stage 3 is rather heterogeneous, and 5-year disease-free survival varies between 89% and 31%. This is perfectly lined out in this paper by Sobrero, where they showed that only 10 to 20% of the patients really benefit from adjuvant chemotherapy, and this depends on the substage between stage 3. But all these patients are exposed to potential side effects. In the Netherlands, we had an observational study in stage 3, 209 patients. All patients received adjuvant chemotherapy. We used a very modern tissue-informed test by LabCorp, and we could actually detect ctDNA preoperatively in over 90% of patients. And after resection, 13% of the patients was ctDNA positive. And in this slide, I like to show you that ctDNA status actually better stratifies for disease-free survival than pathological stage. So the upper graph is ctDNA negative in blue versus ctDNA positive in pink. And you can see the big difference in disease-free survival. What is also important to note in this slide is that there are still a lot of recurrences actually in the ctDNA negative group. It's only 70% of these patients, but as there are more patients ctDNA negative, the number of recurrences is important here. On the other hand, when patients are ctDNA positive, which is the right bar here, about 2/3 of the patients will recur, but it seems that adjuvant chemotherapy can cure 1/3 of those patients, which is really important. The patients, so here we only look at the patients who recurred, and patients in the blue line who were ctDNA negative at the MRD time point actually got their recurrence later on. There are two huge cohorts in the world. One is from the US, the BESPOKE cohort, and they showed that both in stage 2 and stage 3, the ctDNA status at the MRD time point, so after resection, really stratifies patients between at high and low risk of relapse for both stage 2 and stage 3. The same is true actually for the Japanese Galaxy cohort. Here it is for all stages, so stage 1 to 4. You can see the huge difference, and it's the bars in figure B actually show that it's a very important prognostic factor. Here again, for the ctDNA negative patients, there's still about 10% of patients who recur. So that's important to keep in mind. From this study, we learn that ctDNA at the MRD time point has significant prognostic value, but it also seemed that ctDNA positive patients had better effect of systemic therapy. So ctDNA may also be a predictive factor. So what about stage 4? In stage 4, is for us, it's which patients should I operate on, and which patient can or cannot do without systemic chemotherapy. So there are some studies out there, in particular liver metastasis. This is a study by the MD Anderson group, where they actually showed that the patients who were both preoperative and postoperatively ctDNA negative, or the patients who converted from a ctDNA positive status before surgery to ctDNA negative status after surgery, had a much better disease-free and overall survival. What about peritoneal metastasis, and how can we take this to our setting with selection of patients with peritoneal metastasis? What we do want to know is what about the extent of disease? So what about the peritoneal cancer index? Can we perform a complete resection of metastasis, and can we perform a complete resection of the primary tumor? What about distant metastasis? Are they there or are they not there? And what about histology? We want to know something about mutations and whether the tumor is MMR mismatch repair deficient or proficient. So I'd argue that ctDNA can help mainly in the latter two stages, so whether there are distant metastases or not, and in the setting of the dMMR tumors. So maybe to start with this latter category, it's only 5% of the metastatic colorectal cancers, but we now know that immunotherapy should be our first choice. We had the Keynote 177 study in which pembrolizumab had much better outcomes than chemotherapy. There was a crossover, but the median progression-free survival was better in the immunotherapy group. In December last year, the Checkmate study was published in the New England Journal of Medicine, in which they give dual immunotherapy with ipilimumab and nivolumab, which led to much better outcomes than chemotherapy alone, as shown here with a 24-month PFS rate of 72% versus 14%. So we should acknowledge that surgery in this setting is rather adjuvant, actually, and may not even be necessary. It's a bit provocative. Pseudoprogression limits clinical response monitoring. So when you look at CT of a patient who is on treatment with immunotherapy, actually the tumor may increase in size, and it might not be progression at all, but it may just be pseudoprogression. ctDNA may guide us here. And here again, we can learn from the non-metastatic session. I'm very happy that the niche studies were coordinated from my center, and Miriam Shalabi was so kind to share these slides. The niche studies were studies where we used dual immunotherapy, so combined nivolumab and ipilimumab for the first cycle, and then nivolumab as a single agent during the second cycle. And then we operate patients. And as a translational part, we also determined ctDNA using the Signatera assay. The pathological response rate was immense. And this is a waterfall plot, which is now known as a Shalabi plot, which shows major pathological response in most of the patients, and even complete pathological response in 68% of patients. CT didn't help out here, actually, but the ctDNA did. So most patients were ctDNA positive at baseline. This is concordant with the 90% in stage 3 I showed you earlier. And after the first cycle, so just before the second cycle, it is 45% of the patients turned to ctDNA negative status. After the second cycle, before surgery, 83%, and after surgery, 100%. And the disease-free survival is 100%. So in MMR deficient cancers, if ctDNA turns to undetectable, in the metastatic session, we should consider to stop immunotherapy at some stage. We should consider not to operate, and we should consider to repeat biopsies of the primary tumor or metastasis. What about MMR proficient tumors? So here we have the choice between upfront surgery or neoadjuvant systemic therapy. And what we should acknowledge here is that peritoneal metastases are poor shatters of ctDNA. This is work from our department in patients with extensive liver metastasis in the CHIRAL-5 trial, which is the upper left bar, in which we could detect ctDNA in most patients. The second bar is CRC HIPEC, which is a small prospective study, phase 2 study, with patients with peritoneal-only extensive metastasis, in whom we could only detect ctDNA in the circulation in 10% of patients. The third bar is from the Goere-6 study, which is limited peritoneal metastasis, so PCI below 20. About 1/3 of the patients we could detect peritoneal ctDNA in blood using a PCR technique. And when we looked at the ascites of the patients of the HIPEC, we could detect tumor DNA in most patients. In the lower plot, you can see that the levels are much higher for patients with extensive liver metastasis compared to peritoneal metastasis. This is what other groups found as well. So this is a group where they looked at liver only, lymph node only, peritoneal only, and lung only metastasis. And the allele frequencies were a lot lower for peritoneal only and lung only metastasis. So what for the preoperative ctDNA status in our CRS HIPEC patients? This is a small study from our neighboring center in Amsterdam, where they looked at preoperative ctDNA in 24 patients, and they could detect ctDNA using a PCR technique in 1/3 of the patients. And those patients actually had a worse disease-free survival and worse overall survival. I think the next speaker will talk about postoperative ctDNA. But I borrowed this slide that shows that a rising ctDNA after CRS HIPEC actually shows that there's a higher risk of recurrence. This is recent work from our group where we had a prospective study of patients with metastatic colorectal cancer who had subsequent lines of chemotherapy. And we try to track ctDNA with the Signatera assay. And these are just plots of patients with peritoneal-only metastasis. And what I try to show you here is that the scale is a log scale. So the ctDNA values at baseline are really low, and there is some change, but it's not really extensive over time. Even if the patient has progressive disease on the CT, the ctDNA levels do not increase that much. So for those MMR proficient colorectal tumors with peritoneal metastasis, I think it's important to notice that if the primary tumor is still in situ, you will detect ctDNA if you have a very sensitive tests. If ctDNA levels are high in the future, this might indicate systemic disease. So this might be an argument to actually start with systemic therapy. If ctDNA levels do not drop in patients with peritoneal disease, there may be little role for local therapy and HIPEC, but the evidence is not solid yet here. So what we will do in the next couple of months is try to work on the translational data of the CARO-6 trial, of which the results will be published, I guess, this summer in Barcelona. About 358 patients, of whom we collected samples and tissue in 280 patients. And I hope we can get some direction where ctDNA can really help us out. Meanwhile, there are some randomized trials, actually, intervention trials, and the Danish are quite ahead, and they have a randomized study for patients who underwent local therapy of colorectal metastasis. They perform a PET scan, and if the PET scan is negative, they're randomized between ctDNA-guided approach versus standard of care. They have a feasibility run-in trial, and the patients are actually randomized if they are ctDNA positive for FOLFOXIRI, so which is a triplet agent. So take-home messages. For now, ctDNA measurements will rapidly become part of your practice. There are limited data yet to base decision on ctDNA levels in the setting of colorectal peritoneal metastasis. Sensitive tests will usually detect ctDNA if the primary tumor is in situ. You must differentiate between MMR deficient and proficient patients. If ctDNA levels are really high, you might consider to start with chemotherapy. And the time is really right for trials on ctDNA-guided management of our patients. And I hope this will boost implementation in the European Union. Thank you very much for your attention.
Thank you very much, Niels. It was very interesting. So we're going to the next speaker. I think we'll have the question at the end of all the interventions. So the next speaker, it's a great pleasure for me to introduce Kiran Turaga from Chicago, who is going to speak about ctDNA and recurrence in patients with peritoneal metastases from colorectal cancer after CRS and HIPEC.
Thanks, Diane. Thanks, Arthur. And thanks all of you. It's wonderful to see all of you today. So here, I'll just pull my full screen up. And, you know, I know it's, I have a disclosure. I consulted for Merck a few years ago, but nothing relevant today. You know, this is what New Haven looks like right now. So we've moved, I moved from Chicago to New Haven, but this is what it looks like. I know for all of you in Brazil, this is probably very different than what you guys are seeing outside your doors. But this was yesterday when we had a little snowstorm come through our apartment complex. And this is actually Little Italy, part of New Haven. I think I'm going to cover a few concepts. Maybe we'll try to answer some of the questions that are in the chat as well. And I think I just want to preface by saying, you know, this is an interesting and an exciting area. We still don't know exactly what to do, and to reinforce what Dr. Koch had said, I think as the trials and data accumulates, we can really think about how to use this in our practice. So I think for some of the questions, that are asking, what is the right test? What should we use? I think the answers are not very clear, but I think it's important to just kind of think about the concepts that Dr. Koch already outlined for you. We all know from the Fisher hypothesis, or we wonder that all neoplasms, all cancers, especially invasive cancers, they shed cancer cells or DNA or some fragments of it into the bloodstream. And that's what we've always believed. We don't know if that's absolutely always the case or not, and especially in the setting of oligometastases, when you just have a few metastases, the amount of fragments that are shed may be less. But if you really think about, if you were to start measuring things that are present in the blood for liquid biopsy, you can measure many components of things. You can measure exosomes, you can measure DNA, you can measure DNA fragments, you can look at methylated portions of the DNA through the methylome or epigenetics. And really, which one is the best test is dependent both on the circumstance, the stability, and the cost. And so the more you do in terms of getting like a very advanced whole genome sequencing, find the DNA which is specific to the tumor, and then measure it in the blood, that's called ctDNA, so circulating tumor DNA. It's obviously expensive because the first part of the test requires sequencing your tumor, identifying sort of these mutations, and then creating a digital droplet PCR test to find it in the blood. But that's a common one that we use called ctDNA. Similarly, there's cfDNA, where you just measure the DNA in the blood, and you look for common oncogenic mutations like KRAS, P53, things like that. And you say, oh, this is circulating cell-free DNA. But there's also a lot of science in looking at exosomes, RNA, things that are a little bit more stable, that are more, maybe less expensive to do, the epigenetics. But we don't have the right test yet. But I think this is where all of you can also participate in really thinking about how do we think of liquid biopsy for the future. So I'll talk a little bit about, the role of ctDNA in recurrences. And I think the first thing to just know that for those of us that are interested in the peritoneum, I think there's something really remarkable about the peritoneum. When you go inside and you operate on someone with peritoneal metastases, you see all this diffuse disease many times. But yet they may have no visceral metastases, they may have no lung mets, they may have no disease elsewhere in their body, and it's just this very diffuse sort of disease in the peritoneum. And we also know that when we do surgery and we do peritonectomies, quite often you can actually take out most of the disease by just a nice peritonectomy, but the peritoneum itself is such a thin layer. And the issue with peritoneal metastases, and this is data that has been from several studies that have looked at it, when you look for DNA in the blood, it's actually not very, very good for patients that have peritoneal metastases. But it also depends on exactly the type of test you're doing. So if you look at, let's say, a 3-gene assay for cell-free DNA, so you're just looking at 3 genes, the sensitivity is only 33%. If you look at a 73-gene assay through Guardant, that was about 63% for peritoneal disease. And similarly in that sort of range. And in fact, if you look at some papers recently for mucinous tumors, it's still like only 40–50%. So imagine you can have a patient with a very high PCI of 33, 39, and you could have no circulating DNA in the blood, at least from many of the tests that we can do right now. But on the flip side, our good friend Alvaro, that all of you probably know very well, they've found that actually it's not a bad thing to have no DNA in the blood. And in fact, from a clinical standpoint, you could use this sort of information to guide management. So if someone has disseminated peritoneal mucinous disease, like a PMP type syndrome, and you measure it and there's no, just KRAS and GNAS, the common mutations, cfDNA, very cheap tests to do, you can actually predict against systemic dissemination. So you can clearly say this is not the grade 2, grade 3 PMP that you think about. And you already heard this from Dr. Koch, but clearly, and this is very logical, if patients have DNA in their plasma before surgery and they have it after surgery, they're going to do very poorly. If they have it before surgery and it's negative after surgery, they actually do reasonably well. And if it's negative before surgery, negative after surgery, they tend to do the best. So this is it's very intuitive, and you'd say, well, that's kind of a fairly straightforward thing to think about for circulating tumor DNA. So I'll give you one example of looking at peritoneal disease that we looked at, kind of just to think about how this sort of all fits in terms of clinical management. How should we use this information, and how do people use it? So this was looking at specifically appendix cancer patients that underwent ctDNA testing. It's about 94 patients. We had about 80 of them underwent surgical interventions. And then, many of them had ctDNA testing, and then we categorized them into patients that just had localized recurrences. So let's say they've had recurrence right in a bed of where they had resection versus they had recurrence in the entire peritoneal cavity, and then looking at the recurrence analysis. So if you look at this, these are the three survival curves that you can sort of see. This just reinforces the point that for goblet cell adenocarcinomas, even if they're high grade, so grade 2 here, grade 3 here, if the patient stays ctDNA negative, so it's the blue lines on top, you can actually see pretty long survivals. Now, again, these are short median follow-up time, and that's mainly because of the fact that, this is sort of newer thing, and we've been using it more often recently. But clearly, when you're stay negative, you do very, very well, whereas if you get positive after surgery, patients actually do poorly. You can see that the median survival in this arm, if you look at about 50%, you're talking about 1 year. And so for us as surgeons, and surgical oncologists, our concern, of course, is always, are we operating on the right population of patients? A good surgical oncologist is someone who knows when not to operate on someone with cancer. And so are we doing the right operations in these folks? And can ctDNA help us think about who to select for surgery and who to select after surgery for interventions afterwards? So that's one thing that I think is quite interesting when you think of it. Now, this is a swimmer's plot that I think I'll kind of, take a minute to just walk us all through it, just to kind of help you understand what happens with ctDNA. So let's look at just the bottom one over here. So that's the peritoneal metastases one. And if you look at it, this top part is patients that had positive DNA, ctDNA after surgery. This is those that had negative ctDNA. Recurrence is marked by one of these, diamonds, the maroon color diamond, and positive ctDNA is this triangle right here. And the colors here are great. So let's look at people who had, let's say, negative ctDNA. You can see that almost no one in this group here, the low-grade group, no one has recurrence, and no one obviously has positive DNA. So this group actually does remarkably well. However, if you look at this group right here, which is high grade right here, people who have negative ctDNA, only one of the patients developed recurrence. So you can think about, and this is high-grade appendix cancer. This is not colon, but this is high-grade appendix cancer. But you can see that for negative ctDNA, few people, it's not 100%, but a few people can get recurrence. But even after getting the recurrence, the patient still was alive, right, at the time of the completion of the study. So the patient is still alive. So actually a fairly neat way of thinking about negative DNA. Now, if you think about positive ctDNA, you can see that very often the positive ctDNA occurs at least a few months prior to the clinical recurrence. There are a few scenarios, though, where there's patients who have had clinical recurrence, and then you had ctDNA turn positive later. So it is possible that, it's not, again, this goes to the false negative of ctDNAs. And so it is possible that, imaging can pick up disease sometimes before your ctDNA can. But I think what is fascinating is that there's some patients in whom you'll have, they'll turn ctDNA positive. The recurrence happens, several months later. And in fact, there's a couple of patients where so like you can see this scenario, for instance, you have positive ctDNA, no recurrence. You have positive ctDNA, no imaging recurrence. This patient ended up having a bowel obstruction, G-tube, and then died. But really, thinking about, you can actually maybe perhaps find some patients who have disease before that. And I think you already saw this from Dr. Koch when we looked at this in a post-cytoreductive surgery setting. Now, this is for both appendix cancer and colon cancer. Rising ctDNA essentially is positive, in about 90% of these patients that end up having recurrence. Whereas if it's negative, it's not 100%. It's not completely specific for that. But you can tell about 80% of these patients will do really, really well. And the lead time is about 3 months. So you can actually pick it up before radiographic progression about 3 months prior. But the question everyone asks is, well, what do we do with this information? And I would say there's 2 things that I use it for practical purposes. One, we found that when the ctDNA comes back and it's less than 1 MTM per ml, that usually predicts for a peritoneal-only recurrence. It's very rare for me to see, someone with a ctDNA level of like 5 or 10 or 15 to be peritoneal only. Like whenever I see a patient who has a ctDNA level of 2, 3, 5, 10, you automatically know this patient's going to have liver mets, they're going to have, lung mets, they're going to develop bone mets. And that's a very, very, I think a very stark thing. So post-surgery, if your patient gets something like this, you automatically get worried that, this patient perhaps should be more treated with systemic therapy, clinical trials, and that line, as opposed to when they recur with, ctDNA less than 1. I've been much more aggressive in saying, well, I'll go back and do another surgery, an iterative surgery, or, redo surgery, things like that, have been something that I found very interesting in my clinical practice, and we published some of this work before. And then this is another scenario, patient with high-grade goblet cell adenocarcinoma of the appendix, very low PCI score. We did surgery, they got chemo before surgery, and then no adjuvant therapy, just kind of watching on surveillance. Year later, get a positive ctDNA, don't really get imaging recurrence till at least another few months after that. And then the ctDNA spikes up. We started on FOLFIRI. Again, the ctDNA goes to 0. And then we surgically go, cytoreduce, the PCI is low, and then the patient has stayed disease-free since after that. So I do think, you see these patterns that then, guide clinics. Now it's common sense type approach. And, in the US, we're sort of a little bit, you all know we have a very expensive health system and we waste a lot of things. And this is one of those where we do these technologies and insurance covers it. And so, it's used quite often in clinical practice. But I do think it's important to have trials to truly understand what is the value of using this. But it seems very commonsensical to say, hey, if the DNA is rising, you can perhaps do therapies towards it and then treat. And we found it very interesting, certainly in peritoneal disease. I think this is a very similar graph. I won't spend a lot of time on this, but this is from Yuan's group looking at gastric cancer, peritoneal disease. Similar concept, if you have a high circulating DNA fraction in the blood, the patients do worse. If there's, it's not always 100%, and certainly prognostic after surgery. So I do think that, there's many studies that will sort of give you that same sort of information. I think the biggest drawback is right now, we don't always have a very sensitive test. And the second is we don't really always know that by treating a positive ctDNA after surgery, we are going to improve patient outcomes or not. It feels common sense, but, on the flip side, there are studies which have looked at ovarian cancer, looking at CA-125 really didn't change anything, or more frequent surveillance of, colon cancer post-surgery hasn't really changed survival. So will this change survival or not? I don't know. But I think certainly I find it quite interesting. We've been working, I just wanted to put a plug for some of our research as well. And we've been looking at a test which looks at a methylome. We hope that it'll come out for about $40, $50 in the US at least. So fairly cheap test compared to some of these, which are, $10,000, $20,000 for the sequencing pieces. But we have a way of looking at the methylated portions of cytosine. And we've developed a test with which we can actually discriminate between adenomas and carcinomas. We can find different stages of colon cancer. We have pretty nice, in this part over here, you can see that as, you go from polyps to cancers, stomach cancer, liver cancer, you can actually find a fair amount of tumor DNA with very high AUC curves. And when we look at peritoneal metastases, there's no question these are very unique signatures. We can distinguish appendix cancer from colon cancer. We can distinguish goblet cell adenocarcinomas from mucinous cancers. And we can find, patients that'll do really well, that'll do very poorly. So I think it's a very interesting space, no question about it. Like this is a map. It's almost like a new CT scanner of types, this liquid biopsy way of us identifying, prognosis of patients, perhaps putting these patients on clinical trials, perhaps driving therapies based on this. But I think clearly this is a very interesting area overall. So I think, again, I know I've confused some of you with like sort of what to do. And, if you're asking practically, should we be testing this routinely right now in every patient that comes to us? The answer is no, because you don't know what to do with this prognostic information. Is it prognostic? For sure. And will this be very prognostic? For sure. But is it very sensitive? No, because, in peritoneal disease, we're picking up, ctDNA as of today, only 30 to 60% of the time. So it's not a very sensitive test. But on the flip side, if it turns positive post-surgery, it's a very good indicator that your patient will recur. If it doesn't turn positive, it doesn't mean the patient's going to not recur. It's less likely that they will recur, but it's still not a perfectly specific test either. I do think you can use it for clinical decision making. You have a patient that you don't want to operate on, and you can check ctDNA, and if the ctDNA is high, I think generally those patients are not great candidates to go back and do surgery. Sometimes you get that gut feeling, you see a patient and they've got all this very aggressive looking stuff, but they fit the criteria for surgery. But I think things like this have helped me guide our clinical parts of this. But I think, reinforcing what Dr. Koch said, I think really, thinking about trials in this space and doing it in a systematic fashion is perhaps the best way for us to truly understand the therapeutic implications. But I'm also very interested in the de-escalation of therapy. In the United States, we use a lot of systemic therapy for patients that may not need systemic therapy. And of course, then you come with patients with, severe neuropathy and all the side effects. I've had patients on FOLFIRI for 6 years, sometimes before they've come and seen us. And so this can also be used to de-escalate therapy. Like I do think from a patient quality of life standpoint, I do think for us to be as thoughtful about, using this in the setting of, no visible disease, and so keeping someone on maintenance therapy, you can take them off of any type of chemotherapy at all and see what happens. So I do think it has a lot of appeal from a clinical standpoint. So this is a bunch of our lab folks that have been involved in all this work over the years. And this is our campus at Yale. So if you guys come to the US and are in the East Coast and want to enjoy and experience the snow and get away from that beautiful Brazilian sun and the beaches there, you're welcome to come enjoy with us over here. So nice to see you all, and thank you for the opportunity.
Thank you very much, Kiran. This is awesome. This ctDNA hole is really nice, and I think that is going to impact our practice. I'm going to move forward before we start to answering questions and to opening to the discussion. But first, I would like to present Frederico Teixeira, that is from Hospital Sírio-Libanês, and a member of the PSM group from SBCO, from the Brazilian Society of Surgical Oncology. Frederico is going to present a case that will illustrate a conduction using ctDNA, and I think that's going to be very nice to discuss and to answer the questions after his presentations. Dr. Peter Cashin from University of Uppsala is going to discuss with us, and Professor Paulo Hoff, that is a clinical oncologist from Brazil, we're going to join with Guilherme Ravanini, that is surgical oncology, to this discussion. Thank you, Peter, Paulo, and Guilherme. Thank you very much, and thank you, Fred. You can go on.
Hello, everyone. Hi, Arthur. Thank you very much for the invitation. I guess this is the first time that we now have some tests that's more than image tests to predict something more about systemic disease, and there is a lot of space role to understand this. And I'm show you, let's actually, Are you guys, can you see?
Yes.
Good. Well, no disclosures. It's about a lovely lady, 50 years old with no relevant medical history. Unfortunately, she discovered low rectal cancer. This tumor had several independent risk factors: high grade, terminal invasion, vascular invasion, clinically lymph nodes, and she is MMR proficient. About discussion, she underwent a TNT protocol as Prodigy 23 with FOLFIRINOX and subsequent chemoradiation therapy. Unfortunately, the first part of the protocol for FOLFIRINOX, there is no objective response. The objective response by RECIST was just observed after the chemoradiation therapy. And in August 23, she was underwent ultra low anterior resection with total TME and primary colon anastomosis. There is a objective downsizing and downstaging of the tumor. And after she was treated with adjuvant therapy oral capecitabine. This is the total mesorectal excision, R0 resection. In August 2024, imaging tests revealed pelvic recurrence with peritoneal implants and regional lateral pelvic lymph nodes. She was treated with first-line chemotherapy, FOLFIRI, and bevacizumab, but she developed right ureteral compression and happily developing significant pelvic symptoms. After a multidisciplinary tumor discussion, she was indicated a surgery especially to try the symptoms that were developed so fast. As we see here, the PET-CT reveal a large right iliac lymph nodes in the pelvic lateral wall and small peritoneal implants in the hypogastrium with increased glucose metabolism. And after the FOLFIRI, there was a reduction of the level of the metabolic metabolism in the focal areas of pelvic wall and around the right ureter. So objective response in the PET. You can see here some deposits of tumor and lymph nodes, but basically a pelvic disease and developing symptoms. Another point here. As you can see here. And pain, bleeding, infiltrative lesion in the rectum, the colon. The disease was mainly pelvic disease and symptoms. And after a multidisciplinary discussion, we really decide to operate. The MRA also showed at least two mucinous foci involve the posterior musculature of the pelvis and retracted tissue in the common iliac vessels, not invading but near to common iliac vessels, and the progression of pelvic lymph nodes. You can see here in the pressure cow space, the deposit of the tumor, and up here in the perineal muscles, another deposit space, tumor, the retracted lesion, the lateral pelvic wall here, and another one. This lymph node here, another one, next to the iliac vessels. This is a marker of systemic disease, and that's why let's show here. We collect a liquid biopsy, and we show here the minor allele fraction of 0.24% for the mutant Reis, G12D, and APC. So these are the results of the liquid biopsy prior to the cytoreduction. In December 2024, she was operated on, and CC1 peritoneal cytoreduction was achieved without HIPEC. We decided to not perform HIPEC in this case because lymph nodal diseases, and when we look for the results of the liquid biopsy, we are really in the front of systemic disease. APR, retroperitoneal lymphadenectomy, pelvic lateral and pelvic peritonectomy, and this is the PCI of 12. The retracted implant, the mesocolon, pelvic peritoneal. Here we can see some small implants, and the enlarged lymph node of the pelvic lateral wall here. And after the surgery, we obtain again a liquid biopsy, and we do not detect the Reis G12D, and the level of the minor allele fraction was 0.091. It's a kind of objective response, molecular objective response. And here we want to discuss something about the personalized surgical indication of this patient with positive liquid biopsy result before cytoreduction and its clinical applicability, and how good it is a predictor for overall disease-free survival, and how can we estimate the minimal residual disease with the results of these tests. Yeah. Okay.
Okay. Thank you very much for the presentation that highlights the concept of selection of the good patient with ctDNA or not, or the prognostic influence of ctDNA. I think it's very difficult to know if, as said Kiran, if we can do it we have to do surgery to some patients with I don't know if there are some cutoff level with high level of ctDNA or low level or no ctDNA detectable. I think it's the main question. And is there a level that should alert them? And so if I think for this patient, I would have not do the surgery because she had early recurrence, recurrence in peritoneum, recurrence in retroperitoneal lymph nodes. And so I would have done systemic chemotherapy, and only if there was a very good response and prolonged response, I would have done surgery. So perhaps ctDNA may have helped us to decide to do this kind of invasive surgery. So what do you think? And I think we can have a discussion now.
Yes, Professor Paulo will make a comment.
Yeah, I guess being a medical oncologist, I have a different view. And, you know, the main problem with cytoreduction and HIPEC has been that we really cannot prove that we can help the patients. We all feel that there are patients that get help by these procedures, but we have a difficulty identifying which patients can be helped. And ctDNA, of course, it's a great promise. And in the ideal world, either you have a threshold above which the risk would be so high that you wouldn't do it, or so low that you would do it, and or you would identify a response to systemic therapy and see which patients were good candidates to be operated on. So in this case, I think the only reason to operate was to mitigate the symptoms that she had, the pelvic symptoms. Other than that, I don't think that the case really proves a point, Federico, towards using the ctDNA. The patient still had positive ctDNA after systemic therapy, had failed all available treatments that we have, the effective treatments that we have for the disease. There, we still could use TAS 102, or we could use regorafenib, but the chance that this is going to help the natural history of the patient is very, very small. So after treatment, you still had a positive ctDNA. So I think the chance that the patient is going to get cured, it's very, very small. And what about being negative after the surgery? It's better that it became negative, of course. However, the best possible studies that we have, lab studies that we have now, will give us about 85% accuracy. So if you estimate the risk of this patient having a recurrence, you could have, very conservatively speaking, between 10 and 20% of false negative results. So, you know, it's better that it was negative, but I don't think that's, I don't think we can say that's a marker of molecular response, because our test is just not good enough to detect residual disease in the peritoneum yet. So I'm really a little bit skeptical. And there was a question that somebody posed, that's when is it mandatory, when it's an absolute indication to do molecular follow-up? And I was going to say never, because right now it's still very, very investigational. It's something that we want it to work. It's promising, but we don't know what to do with the results yet. That's my opinion.
Yes, that's very important to understand that it's an innovative tool that we are using to manage colorectal and other kinds of cancers. And the aim of this discussion is because we know that HIPEC theoretically can help us to exterminate the microscopic residual disease inside after the surgery. But we also know that there are two kinds of disease. There are people that has locally relapsed disease or local disease, and there are patients that has systemic disease. And in my opinion, the ctDNA is going to be the future to define who is who. Peter, that raised the hand, he did a randomized trial on free cells DNA. And could you comment, Peter, and how did you find and how are you viewing the future using the ctDNA?
Yeah, I mean the study I published wasn't randomized. It was observational, but it basically confirms you know what Dr. Koch and Kiergan have said here. The patients that don't become negative after preoperative chemotherapy, they do very poorly, and in this situation here, the patient was still positive prior to surgery, so that was a definite negative prognostic factor, and also just CC1. In my opinion, CC1, you know, may still have some value in colorectal cancer, and theoretically the HIPEC is supposed to maybe penetrate the 2 millimeters of a CC1, even though we all know CC1 does much worse in the colorectal group. But if you've set a CC1, you already know the patient has cells left, right? So this patient it was a palliative procedure, you know, and maybe it helped the patient symptomatically, I don't know, but obviously the patient will recur. That's going to be clear. Yeah. And in the study I did, it was actually circulating tumor cells that we looked at. But the patients that had cells left after did better if they got adjuvant therapy as well. So I guess there are several different. This case here had already received all the chemo that we usually give colorectal patients, so there wasn't a lot to move to.
Thank you. May I have a question? Do you think that ctDNA could be another predictive factor to decide to do surgery or not? Because we have some. We have the PCI. We have presence of extrahepatic extraperitoneal metastasis. We have, of course, the status of the patient or response to chemotherapy, and we have some prognostic factor that can help us to decide on not to do surgery. ctDNA could be one and could be integrated into the final decision with all the others. We could have a planner or something integrating the ctDNA. What do you think about that for all the panel?
Niels, go on.
Thank you, Dion. I think you're right, and it can be integrated, but it's really early. There are a lot of no-knowns and little knowns. So we definitely need more data, and I think what we have quite a lot of data, observational data from stage 2, stage 3, but also stage 4 patients who are on systemic therapy. But our niche is rather limited with the peritoneal-only disease, and I really can envision that the patients who have a high ctDNA level are actually the patients who will develop systemic metastasis, but we don't know yet.
Guilherme?
I have a question. Thank you, everyone, for the invitation, and congratulations for the presentations. My concern is about the methodology for tracking ctDNA. For example, here in Brazil, in maybe the major institution here in Brazil, the private institution, the basic methodology for ctDNA is NGS, okay? It's not PCR. And for example, in your case, Frederick, I believe that you used NGS. I would like to know if there is going to be a problem or not having PCR by our hand to use in selecting patients, or it doesn't matter. You can use it, the methodology doesn't matter, What do you think about that?
Yeah, I think you may be asking me this question. I'll just clarify, so for Signatera, for instance, which is, it's based on NGS. So they first do NGS, and then you find a few mutations, and then it's a digital droplet PCR. So the first one is always NGS to detect all your, cell-free DNA and your tumor mutations. But then after that, when you have a digital droplet PCR, it makes it easier for your subsequent testing. Doing NGS every time will be just exorbitant, at least for the costs that are right now.
Yeah, for example, here in Brazil, our costs are about 9,000 reals. It would be like 1,500 euros for one test. And of course, that would be very expensive to using the patient control. But do you think that not having this, for example, in the US, I think Dr. Cox said that it's currently being used and you have commercial use for that, and you said that costs are becoming lower. Are you using ctDNA on your practice, on your daily practice?
I do, yeah. I mean, I think for us, the way it is right now, so the way Signatera works in the US is that they'll charge the insurance company for the initial sequencing. And if the insurance company doesn't pay for it, they don't balance bill the patients. So for me as a physician and for the patients, technically none of us are feeling the hurt, right? So ultimately it's the insurance company that is sort of paying for it. I mean, in some way, all of us are paying for it, but so you don't see it on a day-to-day basis. So it's actually easy to order it for patients, and patients don't mind it because they don't have to pay anything for it.
Okay.
But I have a question. To the panelists. In your clinical practice, what criteria do you use to indicate ctDNA pre-operatively? And when performing the exam, when do you contraindicate CRS and HIPEC? Is there any trick for this?
No, I cannot talk for the surgeon, but there are two indications right now. The NCCN has put it out for us to do routinely the ctDNA. So earlier stage colon cancer, because it seems to be a good tool, not to select a patient you want to give chemo, but to select the patient you can spare the toxicity and avoid chemo, and also for Merkel cell carcinoma. So those are the two indications that we have been used routinely, Akaishi. But of course, it's very interesting and it's very intriguing, the idea that we could use it to select patients that could go or should go to a more sophisticated invasive procedure. And I wouldn't limit this to peritonectomies and cytoreductions. We could talk about removal of oligometastases in multiple organs and things like that. So I think we're still learning, but the official use is for early stage colon cancer and Merkel cell carcinoma.
And Kieran, to the Kieran Turaga, in your paper, after you detect a recurrence by ctDNA, what do you do with the patients?
Eduardo, that's like a tough question. It's good to see you though. But I think what it has done. So I'll give you some specific examples. And again, this is I think needs better data. But I've had patients that we've operated on, and then they turned ctDNA positive. And if we're clinically worried that they're at risk for peritoneal recurrence, especially with like either colon or we've gone on and gotten PET scans, and we'll do the colonoscopy, sort of like what you do when you have a rising CEA. But the difference is I do go back and do laparoscopies a little bit more aggressively when the ctDNA is positive and everything else is negative. But I wait for at least 2 tests to be consecutively positive or turning further positive before putting them through a laparoscopy. So that's one thing I've changed in my practice with this ctDNA positive afterwards. If there's patients that are very high risk, and let's say, so, sometimes you get these indeterminate lymph node by the para-aortic area, or you have like some indeterminate pulmonary nodule, and then the ctDNA is positive, then in those scenarios, I have gone, then with our multi-D team, we tend to do more systemic chemotherapy if let's say we've been in the watchful space after surgery or patients are high risk. So it's changed behavior, no question about it. I will tell you it's changed behavior. Whether that behavior is going to change it for patients, that I don't know yet. But we do have now patients that we've de-escalated based on ctDNA, which I like a lot. I think patients like a lot. But then, when you fold it in again, and it's fascinating. Like when you look at the readouts, you can actually see how these clones, they evolve over time, how they change. And then you go operate. Like, it's also made us be more aggressive sometimes. Like, I've had patients whose ctDNAs are really low and they have more mets than I would normally think of doing surgery for, or they have extraperitoneal mets. And normally, you'd just be like, no, I'm not going to operate on this. But then now you're like, oh, look, their ctDNA has turned negative. So then you go clean out the peritoneum, then you go clean out the lungs. So, I think it has changed my practice a little bit. I wouldn't say that I'm recommending that for everyone on this webinar. I think I'm just sharing honestly my experience with this, but I do think with better data, we'll know which way to go.
I think we have the. Oh, sorry.
Go on, please.
We have nearly the same discussion several years ago about CEA for patients who had elevated CEA without any recurrence on the CT scan or anything else, and we don't know what to do with these patients. If we have to do laparoscopy or if we have to do chemotherapy, and we don't know. And this is the same. We can see here if there is a ctDNA and nothing we can see on the radiology. And this is the same. We know that when patients had a very elevated CEA before surgery for liver metastases, so we know that this is a prognostic and predictive factor of recurrence. So this is quite similar for the prognostic factor. And so we don't know actually, as for the CEA, we don't know really how to integrate it in our practice. No?
Who can answer?
I can say something. I mean, I can just answer to the questions before. Here in Sweden, we don't have the wherewithal to send people for ctDNA. So it's not integrated in anything. The thing that I have been working on is purely in research. Patients that want to join a program where we have a partnership with another firm that does it just purely on a research basis. So it's not integrated in any way. And I agree with Diane as well that it's very similar. My feeling is that it may be more specific than the CEA. So the CEA you can chase this way and that, and it gives you problems. I do wonder, since we don't use it in clinical practice, has the ctDNA in the US changed the view of CEA? Has that become obsolete, Kieran? Use the CEA at all?
No, I think because the sensitivity is so low, generally of everything for peritoneal disease, I think we've been just adding on to the information pool. So it's not instead of, but in addition to. I have had very, very few patients where the CEA has gone up, but the ctDNA has not. But in some mucinous tumors, you can see that, where the CEA goes up before your ctDNA goes up. So I do think there's a slight case scenario where I think CEA is better than ctDNA for picking up peritoneal recurrences. I think visceral recurrences are easy to see on scans. Like you don't need ctDNA or CEA for that.
Yeah. And a final question to provoke a little more. If we have a good patient that goes to cytoreduction with or without, and we have a CC0 resection, there is any scenario for Professor Paulo or even to Kiran that you would avoid systemic adjuvant chemo, depending on the scenario? And the other question is, if we avoid, probably we are going to do this on a negative ctDNA after surgery. Would you use, even with low sensitivity, it only without the image to restart or to start a palliative chemo, thinking about a relapse?
Can I
Professor.
start? Yeah, I think the first question is an excellent one. It comes up in every single tumor board. What do you do after you did the surgery and you did the HIPEC? And I guess it will depend on what kind of response you had to the prior chemotherapy. For example, if a patient has used oxaliplatin prior to that and has recurred, I don't see a reason to give more to the patient. It didn't cure before, it's not going to cure now. So we would only consider if the patient, for instance, had received a preoperative treatment with oxaliplatin, had responded, went to surgery, and we still had some space to give a little bit more, I might consider. But I guess it's the opposite. That's the only situation that I would consider giving more chemo. Normally, you already passed that and probably would not give any additional treatment then.
Even in a positive ctDNA after surgery?
The problem with the positive ctDNA is that, you likely have disease, but if you don't have visible disease, probably microscopic disease. And so far, the only treatment that is positive to destroy microscopic disease is 5-FU and plus or minus oxaliplatin. If you have used it before,
yes,
it didn't zero the disease, not going to zero again. Again, if you haven't used it before, then I would consider, but that's a rare event.
And I think, Eduardo or Arthur, to your question, I do think this is a little bit of a dangerous area, like where, I am talking about using it in our practice and I think we're studying it, but I do think there's a patient of mine that was 28, had a MMR proficient, so no genetic mutation, but IBD associated colon primary. I did a CRS and HIPEC for him 2 years ago, and then his ctDNA was positive. And so we did a PET scan. We didn't find anything. We did the laparoscopy. I didn't see anything. His ctDNA has been going up, but we have nothing, like no imageable disease. And this is now almost 9 months, but 9 months of anxiety for the patient. He's had a bunch of tests. We've done laparoscopies, scopes, and haven't seen it. So have we really changed his disease course with all of this stuff? And, I don't think so. So it has its disadvantages, but I think to your question though, we do de-escalate if the ctDNA turns negative and patients had lots of systemic therapy, then I think we're very quick to not do more therapy.
Okay. Professor Akaishi, do you have a comment?
No, that's fine. Thank you.
Okay. So just to wrap up, I will answer some questions. The questions were regarding the best tool or the best tests or methods. I think that we are not going to indicate or say anyone because we don't know it. I think that we are moving forward for someday probably know the better one, but today we don't have it. Professor Paulo has answered about the indications and he numbered it. And I think that, yes, the circulating tumor cells and circulating tumor DNA are different methods that are moving forward to improve the quality of the tests. So I think that we can go on and start to close this session. But first, if I would like to share the screen, I would like to invite everyone to the ESSO Advanced course on the management of hyperthermic intraperitoneal chemotherapy after CRS. this course was used to be held in Hamburg, and now is going to be held in Berlin. We have also a pre-course with video illustrating surgeries, and this is one of the best events. Every surgeon that went know that I am talking about a really good practical course. So I would like to thank everyone, especially the speakers and the panel. You were fantastic, and I think that you move forward the questions and the difficulty that we put it here. The challenge was big, and it was fantastic. Thank you very much. And Diane?
Thank you. Thank you very much for all this very good talk, and for this discussion, very impressive, and I learned many things. Thank you.
Professor Akaishi?
Yeah, I would like to thank for everybody. It was a great webinar, and we learned a lot. Thank you. And
Thank you,
Okay,
everyone.
thank you. Thank you for the audience. Thank you very much.